Hello, good evening, everybody, and a really, really warm welcome to this particular session in the Portman Fireside series of CPD for clinicians. What a treat we've got for you this evening. Now, we've got a double act coming up this evening. Doctors Gillian Ainsworth and Dr Suzanne Lello from our Edinburgh Dental Specialists in Edinburgh, our practice there. They're going to be running part one of this two-part series in collaboration with Guy Slick. And Gillian and Susie are going to be presenting this evening on Atraumatic Extractions. Part two of the series is going to be presented by Dr Simon Nocton from our dental surgery, the dental surgery in the Corn Exchange in London. That's in a couple of weeks' time, so Simon's coming along this evening just to say hello and show moral support as well. If you've got any questions for Gillian and Susie, pop them in the questions box, team, and we'll get them to you. We'll get to those a little bit later on. And as per usual, all of our CPD events attract verifiable CPD. So as long as you stay on for the entire duration, we know who you are, we've got your email addresses, and we will send you CPD in due course. One final thing to say before I hand over to Suzanne and Gillian as well, is that for the next session that Simon's running for us on November the 10th, you'll need a kit from Guy Slick. Now, I'll show you a picture of what's going to be in that kit a little bit later on as well. But for the session to make complete sense to you, I want the first 25 people that want to receive one of those kits, pop your details in the question box, your name and your address where you want those kits sent to, and we'll tie up with Guy Slick and you'll receive your kit, which will enable you to be fully present and prepped for Simon's session in a couple of weeks' time. So I think that's it for this evening. We've got a couple of polls from me for now. We've got a couple of polls coming up for you and some videos as well. So, but in the meantime, I'm going to hand over to you, Susie and Gillian.
Hi, well, good evening, everybody. Thanks very much for joining us. I'm hoping my screen is being shared at the minute. Can we see the presentation, Gillian?
Yes, yes, I can, Suze, thank you.
It's that really awkward thing when you present online, which those of you who've done it in the last year and a half will know, where I'm now basically talking to my own presentation and a small camera and can't see anybody or get any sort of feedback on anything. When we did this last year, Gillian dropped out, her internet went, and I didn't know, and so I was still talking to her even though she wasn't there. So bear with us, we're still adapting to this new way of teaching. But what we're here to talk to you tonight about is atraumatic extractions. And so we're going to fire off. We've got a couple of aims and objectives as we need to ensure that we fulfill the enhanced CPD requirements. So this is basically what we're aiming to cover tonight. And our aim is to give you kind of practical advice, tips and tricks about how to approach your extractions as atraumatically as possible, and hopefully then setting you up, particularly if you are into implantology dentistry. That's the GDC development outcome that we will be covering. So this is the first poll that Andy mentioned, and this is just for us to basically find out a little bit about you. It should only take you a few minutes, hopefully, to go through these questions and just answer the polls that Andy's going to put up.
Suze, really, can I just say that I can only see your first slide at the moment?
Oh, I have moved on.
No, I've still got the front slide.
Oh, good. Going smoothly then. It's paused. Play. Okay. Super. Off to a flying start. There we go. Is that better now?
I'm still on the front slide.
Okay. Can everyone see the aims and objectives now?
Oh, yes. Perfect.
I don't know why I'm asking everyone because you're the only person that can, but that's super. Okay. Is that
I can see them.
Can you see the go-to webinar thing in the top right-hand corner, or is that just me that can see that?
It's the slide with the aims on the left and the objectives on the right.
Fine, but you can't see any of the go-to stuff. Okay, apologies for that technical hitch as usual. Okay, so GDC development outcome as mentioned.
Yep.
Okay, these are the polls that Andy's going to kindly put up for us quickly. And this is basically just for us to gain a bit more information about what level you guys are at, what equipment you have access to, and just to give us a general idea of the audience, because we don't have our usual face-to-face feedback that we would get from you if we were doing this in person. So if you all wouldn't mind just answering those questions, as we will just talk a little bit about atraumatic extractions while you do that. So hopefully this will work. So what is an atraumatic extraction? Gillian, do you want to give us a definition? Do you have a definition?
No, but I think it's an interesting question, because you and I were discussing this just the other day. When I think of an atraumatic extraction, I tend to think of teeth in the upper anteriors. And what I'm hoping to achieve is to extract the tooth so that the soft tissues, the buccal tissues in particular, are as they were prior to the extractions. And the purpose behind the atraumatic extraction is to leave the buccal margin, the interdental papilla, and also particularly the labial plate intact, to help preserve as many of the soft tissues as possible. Whether you're planning placing an implant or whether you're doing a bridge, it doesn't really matter, but you're trying to keep the soft and hard tissues intact. So that's what I think of with an atraumatic extraction. Susan and I were talking the other day about the atraumatic extraction of a lower molar, and I think Susan will perhaps discuss this in a little bit more detail later on. With a lower molar, again, I'm thinking predominantly about the buccal tissues, but Susan and I were discussing the interradicular bone, and we were saying that maybe an atraumatic extraction for lower molar is to keep that interradicular bone, as much of that as possible. So, but I think most people would consider an atraumatic extraction to be an extraction socket which looks pretty much like it did before the tooth was extracted.
That was a very thorough answer, thank you, Gillian. So when we think about atraumatic extractions, we want to think about what's actually keeping the teeth in, so that's the place to start. So obviously we have a bony element and we have a soft tissue element in terms of the ligament, but also the gingivae, which is particularly important when you're thinking about implantology, and also other things like smile line and things come into it as well. So as Gillian said, it's about trying to preserve really as much hard and soft tissue as you can, irrespective of whether it's implants or bridge work or whatever is planned. So really we aim as oral surgeons to approach every extraction in an atraumatic way, regardless of whether the patient is opting for any further reconstruction. What it really involves is severing the connective tissue. We want to minimize any soft tissue reflection that we do, so we're trying to avoid raising flats, because we know that when we raise flat, that we will automatically start to lose some crestal bone by doing that. We want to, with multi-rooted teeth, think about sectioning them and how we can do that in a minimally invasive way, i.e. without raising a flap and without removing buccal bone. And then we also need to think a little bit about our forceps technique when it comes to actually removing the roots. So the way that this, oh, Andy, actually, this is a good point for us to hear the results of those polls, if you've got them, please.
We can't hear you, Andy. Or I can't hear you.
Deafening silence, which makes me panic that everyone's dropped out and I'm just talking to myself.
I can see Andy, but we can't hear you. Nope.
Got a lot of technology. Brilliant. Okay, well, we can come back to that. It'd be useful,
Mixed.
You know. Yeah, we'll usually on, and whenever Andy gets, we can hear about that. So the way that we presented this last year, which seemed to go down quite well, is we tried to make it a case-based discussion. We tried to give you guys as the audience some control over what aspects of the case or what aspects of the process of taking tooth out that you wanted us to discuss, rather than us just sitting and ranting at you about stuff that you're not interested in. So this year, we've picked this case. It was a case that was relatively difficult, and I've called it the case of the Trixie Sixie. So these are the 5 sort of areas that we came up with that we thought would probably be interesting for us to delve into in a little bit more depth. And so what I'd ask Andy, if you could put the second poll up, which hopefully we will be able to hear the answer of, and just see which of these areas you want us to focus the discussion on first. So if you just choose whichever one you think you would like us to discuss, and then hopefully Andy will be able to tell me and we can move on to that. Just quickly before we get the answer, a little bit of patient background on this patient. She was a mid-40s female patient, fit and well, all contraceptive pill, no allergies, non-smoking, no alcohol, so pretty much a perfect patient really. She was relatively nervous, but she had sat through 2 attempts of root canal treatment, so she was happy to have the tooth extracted under local anaesthetic. She was complaining, main complaint was bad taste and breath from this tooth, which was still causing acute pain despite the root canal therapy. And ultimately, she was aiming to have an implant placed. And without getting the result by WhatsApp here, let's just see quickly. Sorry, not so subtly checking my.
And these things start with when it goes wrong.
Excellent.
We'll start at the end and work our way to the beginning.
Indeed. I put the x-ray up here again just to briefly discuss that as well. So obviously tooth is root filled, not quite to the apex. Probably around that distal root, there's maybe a little bit of sclerosis there. The PDL is not quite as evident as on the mesial root, heavily restored, and that all will factor into how difficult the extraction is. Okay, what do we do when it goes wrong? So we'll jump to that.
Okay.
So this was my, sorry, are you all right, Gillian?
Yeah, sorry, do you want to chat about that bit?
Yes, sorry. Okay, so this was my case. So
okay.
As I said, when starting, we talked, I mean, Gillian mentioned earlier about what we're trying to preserve. I agree with you, Gillian, that it's, you know, the buccal plate, the labial plate, even the lingual plate is really the key. We're trying to, you know, maintain a four-wall defect as much as we can. And then we talked about the interradicular bone and whether that was important. The way that this case went, I sectioned the tooth and took the crown off, and that allowed me to take the mesial root out. But then it was that fairly typical scenario, sometimes with root-filled teeth, where every time I got purchased with Luxatus, bits were fragmenting off. So when it got to this stage where you've got that small apex that's left, and you're trying to maintain as much of the hard and soft tissue as possible, then this is where the decision comes, well, what do you do? How do you try and get that root out? When we were talking about the other day, Gillian, you were suggesting removing into the radicular bone, and we talked about using cryers, which may be useful maybe at this stage or this stage, do you think?
Yeah, I mean, the cryers can be quite helpful. It depends very much on the size of your cryers. I think Susan's got some pictures of cryers we might see later on. If the tip of your cryers are quite long and thin, then you may well be able to get the cryers into that mesial socket and chip away the interdental bone, which then gives you better access to the remaining root. I think in this case, it seems to be quite, certainly looking at this radiograph, it seems to be quite a deep, narrow socket. So how much success you would have with the cryers, I'm not sure, but certainly for slightly wider sockets, the cryers can be great. But getting back to the atraumatic principle, you're removing a nice chunk of bone which you may want to use for different reasons at a later date, and therefore maybe that's not particularly atraumatic to do it that way. But that's often how I would do it. Susie's approach is a little bit different, which is great. So she can tell us how she managed it.
So yeah, when I got to this stage, I thought, well, either I'm going to remove this bone in order to get that bit of root out, because I know I don't want to remove any buccal bone or raise any flat, or I can remove this bit of bone here. Now, there are a few things to think about when Gillian and I were discussing this the other day that we talked about. I mean, one, I suppose, is your access and view of that area when you're drilling. Certainly the interradicular bone will be easier to visualize than that small distal bit of bone there. But you can see on the x-ray, there's no sort of 7 root nearby to worry about. There's no sign of ID nerve anywhere nearby, which is something that very occasionally can be sitting high in this area. So I was fairly confident in terms of drilling there. Another point is whether you're using magnification or not. So as I kind of traditionally taught in max units, oral surgeon, I'd never really used magnification for my surgery until fairly recently, probably the last year or two. And I feel it's made like a massive difference, as you will all know, if you're working in general practice, because I'm sure most of you wear loops for most of your work. But that's really been a game changer for me. So this, you know, when the root finally comes out, you kind of look at it without loops and you're astounded at how small it is, because it looks obviously bigger in your loops. So that's one thing that Gillian mentioned about, with somebody working in general practice who's maybe not got as much surgical experience, be happy drilling distally in that area. And those are the sorts of things you need to think about, obviously adjacent roots, any other anatomy that's nearby. Do you have anything to add to that, Gillian?
Yeah, can I just talk in a slightly more general aspect? What do we do when something goes wrong? Can you go back to the original radiograph with the whole tooth in it?
There you go.
Thanks. So if you look at this inside the mouth, I'm guessing that this is some kind of crown on it. You want to extract it. So probably what you're going to do is maybe put your crowns or your lower molars on it. And then I know, Suze knows, you'll probably know too, that that crown is going to come off. And then at that point, it kind of depends on what your definition of is, has that gone wrong? So that hasn't gone wrong. That's just something that's to be expected for this tooth. So your crown is going to break off, and then you may be comfortable, you may not be comfortable in progressing to the next stage. I think everybody's idea of something going wrong will vary enormously. And just looking at the slightly bigger picture, I have taken out many roots for dentists who perhaps the dentists think that something has gone wrong because they've taken the crown off it, they've not been able to get the root out, they've got one root out, they've left an apex, something has happened and the dentist hasn't been comfortable with it. In the grander scheme of things, these patients will then often go away, and yes, they will be in some discomfort for a couple of days, but I don't think I've ever seen a significant infection from something which has gone wrong, from a retained roots. The patient suffers pain, but the roots can normally be retrieved relatively easily by somebody a little bit more experienced. So I think what I'm trying to say is, if it goes wrong, as in, if a tooth breaks, and if you feel comfortable to progress with it, and hopefully by the end of today we'll give you a few more skills and tips in that, then that's fine. But I wouldn't get too worried about leaving roots or apices in place, because apart from some pain, and obviously the situation does need to be managed, but it's not a catastrophic dental emergency. It's just something that needs to be addressed, preferably sooner rather than later. So I think what I'm saying is, don't worry about it.
Yeah, I guess the main thing really is how you've communicated with your patient prior to starting. So if if I see a patient like this, I will explain to them that it's more than likely that the crown or the tooth is going to crumble as I start working on it. And actually, one, they're going to hear some funny noises, and I'll try and warn them if I think I can predict when that's going to happen, but try not to panic if you start to hear funny cracks and crumbles, because obviously it's different when it's in their head to what we're hearing. And also, that's expected. It's an expected part of what is going to happen. And so if it does happen, then you've already preempted that, I guess. And so hopefully then they're able to manage that better themselves in terms of, their anxiety about that it's not going well. So yeah, as usual, a lot of this comes down to communicating well with your patient beforehand, the informed consent process that we all know we have to go through. So yeah, I would say that's another tip as well, actually, is warning them when it's root filled that there's a good chance things are gonna break as you work, and that if you can't deal with it, you'll be able to refer them to somebody that can. I don't know if you agree with that, Gillian. Does that sound reasonable?
Yeah, I was just thinking it leads on to a slightly different thing. At Edinburgh Dental Specialists, we have written consent. So for any surgical procedure, we would fill out a consent form to let them know the procedure, the risks of it, the cost of the treatment as well, and then they would sign it. For the more advanced work, we have information booklets which we give the patient at the time of consult, and then they go away and read that, and then they sign it on the day. I think I'm right in saying that having the patient's signature on a bit of paper doesn't mean that you're not responsible for anything, but it is at least evidence that you've had a conversation with the patient. But as Sue says, communication is essential.
Yeah.
Shall we move on to Luxatus versus elevators?
Yeah, don't get me talking about consent, because I will talk about it all night. It's one of my passions. Luxatus versus elevators.
That's another night.
Exactly. It's bad, isn't it, really? Luxatus versus elevators, that's the next choice, is it? Okay.
You had some slides. Yeah. Here we go. Shall I chat about these for a minute or two?
Absolutely.
So Suze might want to flick slides as we go along. So my protocol for extractions is to start off with the periotomes, and you've not asked us to chat about that, so we'll gloss over periotomes for the moment. But my protocol is periotomes, luxator, and then it's normally forceps. The elevators, as in the Couplands 1, 2, and 3, I don't routinely use for extraction. Again, thinking back to the upper central incisor, for example, think about the atraumatic extraction, we want to keep the bone and the buccal tissues. I start off with the finest instrument, which would be the periotome, and then I would move to the luxator. And perhaps if Suze can flick through, there's a slide with the different sizes and shapes of luxators. I wouldn't get too worried about the handles. The handles just refer to different manufacturers, obviously. Luxators come in lots of different shapes and sizes, and I've been working in another practice recently that has luxators with different angles on them. The point is, and if Suze flicks back to the other slide that had the luxator and the Couplands on it, in that top left image, there's a Couplands on the left-hand side and the luxator on the right-hand side, so that you can see that the luxator is a very finer instrument than the Couplands. Some luxators have got square corners to them, a little bit like Couplands. Some of them are a little bit more rounded, but it's a finer, thinner instrument. So, excuse me, the luxator is quite helpful for putting up into the periodontal ligament to help break that PDL and to widen the space. The elevator, as in the Couplands 1, 2, or 3, if I'm taking multiple teeth out, I would use it between the teeth. And Suze has also got she's got a diagram of this, of different fulcrum points. Yes, perfect. So position 1 is perhaps where I would use a luxator to put it down into the periodontal ligament. The position 2, where I'm taking out both teeth, clearly you don't want to lever against both teeth unless you're extracting both of them, I would more likely to use for the Couplands. Couplands 3 I don't tend to use at all. I think it's a really big chunky instrument. Couplands 2 would be my favourite choice. And the Couplands 1, 2, and 3, they don't seem to vary as much as the luxators do. The luxators come in so many different sizes and shapes. We used to describe them as 3 straight or curved and 5 straight or curved, but to be honest, I think there's loads of different types of luxators. Fine ones are really great for lateral incisors, and particularly if you've had fractured an apex off, and then slightly bigger ones would be better, clearly, for bigger teeth. So I think having a selection of luxators, of the width of the luxator is really helpful, and having some Couplands 1, 2, and 3. But I would say a luxator I use for virtually every extraction, and a Couplands rarely.
Yeah, I mean, as you say, the application point is key. And if you have in the back of your mind, whenever you're extracting something, particularly if something's gone wrong, or you've got a root that's reticent to coming out, the basic principle is that you need 2 things to take any tooth or root out. One is an application point with an instrument, and the other is space. So if you are ever struggling with a tooth, or when you've sectioned a tooth trying to take roots out, you need to have an application point and you need to have space. As Gillian says, the application point is also very important. We need the fulcrum to be on sound bone if you're not extracting both teeth, or you can use it on the adjacent tooth as well, as she says. But if you're ever struggling, just have in your mind, have I got space? Have I created space? What shape is the root? Does it have a curve on it that means it wants to go that way? Do I have space over there? And do I have an application point where I can actually apply force to the tooth to start to move it, whether it be with forceps, luxator, or Couplands if you use them. Quickly go over the principles of luxators and elevators. So the wedge principle is probably the most commonly used one, and that's where, like the blue triangle you can see on the screen there, it's essentially the theory that the instrument is narrowest at its tip, and then they get wider as they go towards the handle. And so by forcing the instrument down into that PDL space, by wedging it down, the further apical you get with the tip of the instrument, the more that wedge principle is going to start to move the root or the tooth up. When you're using the wedge principle, you're forcing that instrument down the long axis of the tooth, and then ideally you want to be turning the instrument on its long axis. Levering is the other way to use these sorts of instruments, not so much your luxators, but your elevators, because if you lever with a luxator, you may damage the tip. But if you're using a Couplands, you can lever. But I would always, particularly when you're starting out using these instruments, be very careful levering too much, because the amount of force you can put on by levering versus turning the instrument on its long axis is far greater, and you're more likely to break things. So if you start to get fed up like me when I was breaking that root off all the time, it's probably because I was levering it before it was ready to move, and I was just taking more and more of the roots off. So they're the only other couple of things I would say. The only other thing I would mention actually with these is this principle of creep, and I don't know if you guys are aware of this, but essentially it's a biomechanical principle which states that the material continues to change shape over time under a constant load. So we can relate this to extractions both in terms of the soft tissue and the hard tissue. This graph is actually taken from an orthopedic paper talking about tibial bone, but obviously bone in the body is similar everywhere. So if you can imagine this curve when you're actually going through your instruments, so say you apply a luxator into that PDL space, you're going to get some instantaneous displacement of the bone, and we know that because we're able to fairly easily most of the time push that instrument into the socket to a point where it meets resistance. So that's the initial elastic displacement. And then you have this sort of flattening of the curve where not a lot is happening, although the bone is slowly expanding. And then if you get to the point where you get beyond the elastic recovery of the bone, then you'll break the bone. So that's a little bit like when you were taught at university probably to put your forceps onto an upper six and go buckling, apically and buckling. And then a lot of the time you would take the buckle plate. It's because you would reach that point where the bone wasn't able to give anymore because you were moving so fast in that direction without any other expansion of the socket, and hence the bone would break. So it's just a principle really to have in the back of your mind. Again, if you're struggling, it's about taking your time, and it's probably the most common thing that I say to students, postgraduate and undergraduate, when I'm teaching oral surgery, is to slow down and take your time, make your movements purposeful. There's nothing that irritates me more than people like sitting and elevating like this, or they're kind of, you know, going with the forceps like this. You know, really just slow everything down and give that soft and hard tissue time to creep, give it a little bit of time to move out of the way, and that you'll find that actually makes a big difference. So in a practical sense, it would mean moving the tooth to a, you know, so move it buckle the upper six, but hold it there for 10-20 seconds. It's about 60 seconds or so, I believe, that you get to breaking under a constant load with bone. So hold it there for 10-20 seconds and just allow that bone to give a little bit, and then take it to local and the same process, and just make it a slow and purposeful exercise rather than lots of sharp, sudden movements, if that makes sense. Okay.
I think along this.
Yeah, sorry, Gillian. Yeah.
Yeah, just along the similar lines, thinking about what I was saying a few minutes ago about the different size of elevators and Couplands, I was always taught to make the most out of every single instrument. So you don't pick this instrument up and then just use it for a few seconds and that's not going to work. I need a different one or a bigger one, or, you know, whatever it might be. It's making the use of every single instrument. So although the Couplands come in 1, 2, and 3, if I was using them, I don't routinely start off in a 1 and then, you know, move to the bigger and then so on. It's making the most of each instrument. Going along Susie's lines regarding the creep, you can put an instrument down and you can push it and you can twist it and you can get that creep and you can get the expansion of the socket, and then you can push the instrument down a little bit further and you can do that rather than just getting a bigger instrument. Looking at the slightly, you know, looking at the work efficiency, it's a lot more efficient to use one instrument to the utmost of its capabilities than to waste time putting that instrument down, picking another one up. Depends on your 400 dentistry, of course, but it's a lot more efficient to use one instrument for as long as you possibly can until, you know, you cannot do any more with that than just picking it up and, you know, frustratingly getting another instrument and trying again with that one.
Yeah, absolutely. And I mean, this is just a reminder that these instruments are sharp and you don't want to slip anywhere with them if you can help it. And so how you hold it actually is very important in terms of having a finger rest on adjacent tooth, or often I use my supporting finger from my other hand and I rest on that. But it's also important to have the instrument sitting in the heel of your hand, because to use these instruments effectively, we actually do need to apply a fair amount of force, and that's another thing that you know, students will notice, or particularly patients will notice if I take over from a student, is the difference in level of force. And obviously that's something that you get more comfortable with the more experienced you are, how much force you can put on before something is going to break. And you only really learn that by breaking a few teeth. But you know, having it in the palm of your hand like so means that you can really bring the force from your shoulder, think about your positioning around the chair. I mean, really go back to basics, particularly if you find yourself in a situation where you're struggling with a tooth. Think about how you're positioned, and are you, as Gillian says, you know, are you using that instrument to the most that you can, but also are you in a position where you're able to use your physicality in the best way that you can, if that makes sense. And so that's just another thing to bear in mind, particularly if you're struggling. Okay, what's next up? We have talked about that now.
Sectioning teeth.
Sectioning
You've got that
teeth.
photograph, Suze, of
sectioning teeth. I do. This one. Are you there? Has Gillian disappeared? Okay. I can't see what's going on because I'm staring at the presentation, but I shall just carry on. So we'll talk about sectioning teeth. This is essentially allowing you to minimize the bone removal that you will need to do.
Oh, that's better. You're back.
Are you back? Am I back, or are you back? Is it me that dropped out?
I lost you for a few minutes.
I apologise. You asked for the photograph. This photograph.
Yes.
Is that the one? Right.
No, that one. I'll chat about this one for a couple of minutes. Excuse us, the joys of technology. Yes, I quite like this photograph. We were talking, or you guys wanted to talk about sectioning teeth, and I think this is quite interesting. Again, it demonstrates quite nicely the different, or not different, just different approaches that Suze and I have when it comes to sectioning teeth. So if I had an upper molar that I needed to section, I think by default I would just cut a flap. I don't know, maybe it's just going back to my basic principles that you need to cut a flap in order to get to the buccal bone, remove some buccal bone, and then you can section it. I know Suze doesn't always do that, but anyway, these pictures are great. I quite like taking out upper sixes. If you are going to, or you break the crown off and you feel that you need to section it, I would cut just a wee flap, because I think if you cut a small flap, it then allows you to get to the bifurcation that makes the sectioning process a little bit easier. I would perhaps say to not cut a flap is maybe a slightly more advanced way of doing it, but I'm quite happy for Suze to have a different opinion on that one. Anyway, when it comes to upper six, you're more advanced than me. Let's not get into that one. Anyway, so for the upper six, you would, if the crown had broken off it and I wanted to section it, I would always start off by sectioning the buccal roots. The thing with upper sixes is that it's three rooted and you don't know what the palatal root is going to be attached to. So if you section it buccally, as in that top right corner, and then put your couplins into that fracture line, you will then fracture the mesial and distal buccal roots. And in that process, you will probably find that one of those roots will separate from the palatal root, but you don't know which one. So it's kind of a little bit of a game, which way it's going to go. But the point is, if you just section it buccally, fracture it with the couplins that Suze can show us the diagram in a minute, you will hopefully then be able to take out one of those roots, and then it's possible that the other two roots, the palatal, whichever the remaining buccal root is, may well come out with your forceps. So you might not need to do the second section, which is to completely separate the palatal root from the buccal roots. anyway, that's just my experience of it.
Yeah, absolutely. I mean, I find it a pain positioning wise to try and section upper sixes. And I think I should probably evolve more and use a contra angle handpiece to do so. But
lift a flap.
So yeah, just in terms of sectioning principles, starting out, this slide is probably more relevant to 8, but it's useful just to bear in mind that when you're sectioning, you can see the burr in the bottom left corner, and you want to really only go to the depth of the cutting surface of the burr, and then you'll know that you're not going through the other side of the tooth. It's probably, I mean, that point is probably less relevant here because, like you can see in the top left hand side there, lower molar, if you don't section all the way through, then when you try to elevate, you could still have a portion of the crown that's preventing the tooth from coming out, if that makes sense, or a portion of the root that it's butting against. So actually, in some ways, when you section in this scenario, you do actually want to section all the way through the root completely, so to completely separate them. But you just need to obviously make sure that you're not going through the lingual tissue. So you need to have good visualization, which is easier in the lower jaw than it is in the upper jaw. And then another sectioning principle is that you don't always need to section all the way through. So when you fracture it, you're protecting the tissues, surrounding tissues, and any anatomy there. We're kind of going backwards on these slides.
Can I just ask?
Yeah, go for it.
Suze, can I just ask, if you go back to that other slide, you had a Fisher burr. Do you ever use a round burr for sectioning, or do you do everything with a Fisher burr? I
never use a round burr for sectioning.
You don't ever use a round burr for sectioning?
I don't ever use a round burr for sectioning. Do you use a round burr for sectioning?
Okay. I would use a round burr to cut away the buccal plate. I know this isn't atraumatic, but anyway, I'd use the round burr to cut away the buccal plate, and then I would often use the round burr to make a wee hole, to make a divot in the root surface. Yeah. I feel, rightly or wrongly, that the Fisher burr is quite good for the lateral movement, but I quite like the round burr literally to punch a wee hole in it. But yeah, it's a personal choice.
Yeah, no, absolutely. I mean, I actually very rarely use a round burr even for bone removal, which I think stems from my NHS days as an SDR and only being allowed one burr on my tray. And because I want section, so I'm so used to using a Fisher burr now that's what I tend to use for everything. But I mean, yeah, obviously there's 10 ways to skin a cat, so you know, whatever works for you. And you make a good point in that the tip of the Fisher burr isn't brilliant at cutting directly, so that initial divot is you have to put on a fair amount of force, I can imagine, compared to a round burr. So absolutely, you've just got to find what works for you. There's no right or wrong answer, is there, to any of this, really? So yeah, it's a bit of playing around and trying different things and seeing what works, I suppose, most predictably in your hands. So this slide is just a bit on why we section teeth, which I was talking to myself, I think, when I dropped out going through this. But essentially, your aim is to create space. As we talked about, you need application point of space. So you're going to create space by sectioning teeth. And then you can also remove divergent roots on their separate paths of withdrawal. So particularly useful if you've got two curved roots. And obviously, we're trying to avoid damage. So the kind of golden rule is if you're finding it's not moving, particularly you know, upper molars where the buccal plate can be very thin, don't force it, just divide it. Divide and conquer is what I usually say to my patients. I need to divide and conquer. Okay, what topic was next and how are we doing for time? It's 8:10. We maybe have time for one more before we go to questions, unless there are no questions, in which case we can discuss the other ones. Do we have any indication, Gillian, of which topic people want us to talk about?
Gillian's frozen at the moment.
Excellent.
Yeah, she's. But next on the kit, we've done Luxatus versus elevators, done sectioning teeth, then Peritones, and then other kit was last of all. Okay,
so we'll go to Peritones then. Will you let me know, or Gillian will let me know, I'm sure, when she comes back in. So Peritones. This is the instrument that we tend to start with. Both Gillian and I routinely start our extractions with a peritone. And as Gillian said before, we tend to start with the smallest instrument and then work our way usually through Luxatus, definitely. Occasionally I will use couplins, depending on the clinical scenario, and then usually a forceps just to finally remove the root, by which point it should be pretty loose, so you're not really having to do much expansion with the forceps. Peritones, I find them interesting to use. I'm probably getting more used to them as I go on. You can use them with a mallet. So I know a particular surgeon that likes to, or certainly used to use a mallet to use the peritome. And having done it, it is really effective. But obviously patients under local anaesthetic, most of them don't tolerate that very, very well. You can prepare them for it and they will accept it, but it's, I wouldn't say it was a practice builder necessarily, but it is really effective. A way to use a peritome. So most of the time, both Julie and I would tend to use them just by hand. And there are two things that I'm aiming to do with them. The first is to cut through, obviously, the periodontal ligament fibres that are particularly surrounding the cuff of the tooth. So I kind of work my way sort of buccally and lingually or playfully if I can with it as well, depending on the angle that I'm working at and whether I can get it in at the right angle. And then the other thing that you can do with it is, again, starting that principle of the creep, the biomechanical principle of creep. You can start to move it down the root surface. So, you know, cutting the PDL, starting to cut the PDL further down, a bit like you would a luxator, and making sure you've got a good finger rest, obviously, when using it. And then if you just hold it there, again, hold it for 10, 20 seconds. So you force it as far down as you can and just hold it in that position. You can then give it a very gentle turn. Now, obviously, you're not aiming to actually apply much force to the tooth, you're not elevating the tooth, but just turning it ever so slightly will just start that expansion process. And it's just taking your time and working your way around the tooth like that. And that's how I tend to use peritome, but it's certainly the one that we use at the beginning of most extractions to get us going. And then you kind of incrementally move on to a small luxator and then a larger luxator if you need to. I'm assuming Gillian is not back, so I don't know if there's anything she would want to add about luxators, peritones even, because I can't see anyone.
She's back, Susie.
She's back, oh great. Super. Is there anything you want to add, Gillian? Although you probably didn't hear anything of what I said, but.
Oh, Gillian, you're on mute. It's all going on tonight, isn't it?
Can you?
That's a while since we did a
sorry.
webinar.
There we go. How's that?
Is there anything, did you hear anything of what I said? Is there anything you want to say about peritomes?
Yes, yes, there is. The periotome on the left-hand side of that image is the periotome that I use most frequently. The periotome on the right-hand side, as Sue says, you just have to have a little bit of understanding, good communication with the patient, because you're going to hit them with a mallet, or as a patient said to me the other day, so you're going to get the toffee hammer out. Anyway, the thing about the periotome on the right-hand side is that the blade is removable and replaceable. So at the end of that handle, that little wider bit just unscrews, and you can take that blade on and off, chuck it in the bin and go and get another one. The peritome on the left-hand side, that is not the case. So it clearly needs to be sharpened. And it depends on your sharpening, your instrument sharpening skills. We have a little wheel that you plug into the wall, and the wheel turns, that you can use for sharpening your instruments. There's also a sort of stick, for want of a better word, which is kind of about so long that you can use that to sharpen your instruments. The peritome on the left I do prefer because of the angulation of it. The one on the right hand side, it's great literally to hit straight down into the socket, but is less good to try and get round the buccal and lingual aspect. But I do like the fact that the one on the right, the blade is replaceable, because the one on the left, it will just become blunt after a while. But I would, getting back to what I was saying earlier on about luxators versus couplins, if you look at the size of that periotome, the thinness of it, when you're taking a tooth out, you can get a really thin instrument in first of all and kind of break the PDL and sort of widen things. And then after that, you put a slightly wider instrument in, which is probably going to be your luxator. And then after that, thinking about your upper central incisor, the forceps that I use most commonly now would be root forceps. Over and above universals or upper straights, I use root forceps for virtually everything.
Right.
So,
super. Okay. Well, what time are we on now? The last one to go through is other kit. I mean, we can fly through that and then take some questions if there are any at the end. This is just some useful bits, and we may as well. So, other useful kit. You'll be familiar with these different types of elevators, so curved Warwick James and cryers. The most common time we use a curved Warwick James, I think we're in agreement on this, is an upper wisdom tooth. I do occasionally use it to raise flaps as well. It was originally designed as a periosteal elevator, and it is quite useful for that, particularly around impacted 8s, just to get the gingival cuff up before you then start to raise with something else. And a cryers, we've mentioned it before, you know, to dig root sites, fractured roots in 6 sockets. I also occasionally use it for an upper 8 if it's quite high, but you've just got to be a little bit careful with it because it can apply a lot more force than a curved Warwick James. And also, it's the only instrument, well, it's the only thing I've ever had a needle stick from twice. Both times I've had a needle stick with patients, it was both times it was a cryo, so do just be cautious with them, they are sharp. Anything you want to say about those, Gillian?
Only that I mentioned earlier on when you showed your radiograph of the Trixie 60, the cryers, the dimensions of the points can vary. So some of them are a little bit longer and thinner, and some of them are a little bit more short and stubby. So I would suggest that you have a couple of different sets of cryers in your practice, so that you've got different bits of kit for different uses. And I think we've, Susan and I have both been involved with various reasons for purchasing some instruments recently. Now, I think trying to buy instruments through catalogues and through the internet is really difficult. I was at a conference recently and they had quite a lot of instruments on display. I'd like to be able to pick them up and have a look at them. It's difficult to get a feel of the design of it when you're looking at it in a catalogue. But anyway, that's a small minor point. Cryers come in different shapes and sizes, so have some different versions.
Great. Okay, wait a minute. Why is that not moving on? There we go. I threw this in, actually, Gillian, you haven't seen this slide, but I threw this in because I heard about it this morning, the root pick, which I have used a couple of times. It's actually really good for those tiny little bits of fruit. It's a little bit like when people you know, use a file up the bit of fractured roots, which I have done once.
Okay.
It's quite new. But it's got a really fine point, and you can just sometimes get it down beside the root and just flick the root out. So that's another piece of kit that can be quite useful in terms of rescuing you from a sticky spot. Root forceps you've mentioned, and yeah, most of the time that's what we would be using, particularly having sectioned roots. And then a brief mention for cowhorn versus eagle beaks. Cowhorns being the originals, and then eagle beaks came later, designed slightly differently to get a better grip of the crown of a tooth when using them for an extraction. But this is probably the sort of scenario that I might just head straight for my cryers or my eagle beaks, when you know that there's not going to be a lot of resistance, and either the tooth is going to section, or if you're really lucky, just pop out, and that can be quite satisfying to do. The movement with these is more buccolingual, so you're not really doing like the kind of traditional figure of 8 movement with them, and you're kind of rocking buccal to lingual whilst squeezing, and that allows the beaks to get into that frication and start to squeeze up. So either you'll separate the roots and be able to fit them out separately, or sometimes, as say, in a young patient where there's a lot of infection, the tooth will just pop up. Anything you want to add about those, Gillian?
No, the only thing that I was going to say about root forceps is stating the obvious. They're just a smaller version of universals. Again, forceps come in a multitude, excuse me, a multitude of shapes and styles and designs and manufacturers, but the root forceps are simply a slightly narrower, thinner version of universals. Sometimes it can be difficult to tell which are roots and which are universals because, you know, the designs can be quite similar, but choose something which is nice and fine with a narrow tip on it. Eagle beaks, I'm not sure that I've ever used. I tend to use cowhorns or molars. The cowhorns are particularly good, as Susan's alluded to, in the younger patient. There's nothing more satisfying than putting a cowhorn on a lower 6, squeezing it, and it just pops out of the socket. It's one of the joys.
Okay, so the final thing that we could do is just show the video, which is about a minute long, and it just demonstrates these instruments. It does go quite fast through them, but if you have got that, Andy, we could show that, and then I think we should still have.
I'll have to take your slides down, Susie, for me to share.
Oh, yeah.
Right. Okay. Which video would you like?
The one that is entitled Peritone, Luxator, Elevator, Cow Horns.
Cow horns, great, I saw that earlier on. Let's play that one. Can you see that, Susie?
I'm muted, apologies. I was just saying this video I recorded at home last summer with a pig's head, so just apologising for the slight DIY. But that first instrument was the peritone. We can maybe show it a couple of times if people miss it, but that was a peritone going round, cutting the ligaments, and then this is using the luxator, so I'm applying a little bit more force, pushing down, and you'll see when I get to the distal aspect of the tooth from the position of my finger how far I'm managing to push that instrument down the root of the tooth. And it's all turning on the long axis. I'm not really levering with that, so I'm applying the wedge principle here, just wiggling and pushing, kind of wiggle and jiggle with an apical force. Then we move on to the couplins, and that you can see it's a much more purposeful movement now. I'm starting to really turn that instrument on its long axis and levering a little bit on the tooth, and that you can see that's applying like a purposeful force, and it's actually making the tooth start to move. And then a quick demo of cow horns just to separate roots, so squeezing them together, buccal lingual, and you can see it just fractures, and then quite often you'll get a root out in that way. So yes, it's a bit of a fly through, I'm afraid, but hopefully I'll have a clinical video one day to show, but that's it for now. Right. That's the offering. So
did you want to show any of the others, Susie?
No, I don't think so, because we haven't really talked about that stuff much. Thank you, though. Okay. That's it. Good. So that's us done. That's our offering over. So if we have any questions, I'm happy to take those now.
I have got a couple of questions actually. Deb was asking a great question here. Do you section with a fast hand piece, Susie? Deb was aware about the risk of emphysema. How great is the risk of that during the root separation?
Well, I never use a fast handpiece. I might if it was a reverse air handpiece. I think that's fine. But if it's your normal chair size fast handpiece, then no, I wouldn't. I have seen a patient with a surgical emphysema, and it isn't much fun for them. But I know that people do, and I know it's done a lot. I know the rate of complication is low. In fact, there is a paper that just came out that Sammy Stagnell published with a couple of other people as well, talking about this. I haven't actually read it yet because I only saw it last week, but there is a paper just been published on, I think, the prevalence of use of fast handpieces, and I read the conclusion, which was that you shouldn't do it because the consequence for the patient is quite severe. If they do get it, it's not much fun for them at all. So yeah, my answer would be, as an oral surgeon, I would say no. Gillian, would you agree, or?
I think you'll get quite a biased view on this. As specialist oral surgeons, Susan and I are lucky enough to always have access to an electric motor. So I'm quite unequivocal about it. No, I would never use a high speed. I would always use an electric motor. However, I appreciate for the vast majority of GDPs, they might not have access to the same equipment as we do. Can I just say just briefly that I have seen a few surgical emphysemas. I created one myself a few years back, which was really quite interesting, and we're still not exactly sure exactly how it happened. It was an upper 5 that we were taking out, which was a really difficult extraction. It wasn't particularly close to the sinus. I can't remember. I think we might have used the handpiece. Yes, we did use the handpiece on it, the electric handpiece. And the patient was really quite upset throughout. And when we finally stopped, she was sobbing. She was really quite traumatized over the experience. And it was really instantly that she started to become swollen. So she became swollen over her cheek, and it went down to the side of her face, just underneath her neck and along her chin. And I'd seen it once or twice when I worked in dental hospital. I'd seen patients being referred in with surgical emphysema. So I knew instantly what it was. And it really is quite it's quite alarming, I suppose. She continued to swell up for about half an hour or so, but it's also exceedingly characteristic. It was just like having Rice Krispies, that sort of snap, crackle and pop. You could feel all these tiny little air bubbles. So we kept her for a couple of hours in the practice. I gave her some antibiotics. We sent her home. We phoned her again when she was at home. We phoned her again the following day, and the emphysema did go down relatively quickly. But it was quite an interesting case because I still don't know exactly why it happened. But the emphysema happened very quickly. I've lost an earphone, and it resolved within a few days. But quite distressing for her and a bit disconcerting for me. So it can happen, even
without a high speed. So then,
yes, there was no high speed involved.
Yeah, okay. But yeah, I think the high speed we know is a high risk for it. So yeah, but Gillian's right, we're biased because we have access to that. Although with a red ring nowadays, a lot of dentists will have access to red rings, and maybe that would be safer. I mean, they're electric motors, aren't they? So
I don't know.
Hopefully that sort of answered your question.
It was a really good debate there, ladies. Thank you so much. Fantastic. Asita is asking, any tips on how to avoid tuberosity fracture?
Yeah, I've seen a few of these as well, and I've created one or two.
Yeah, I've created one or two in my time. Yeah.
Again, going back to my dental hospital days, I've managed a few tuberosities that have been sent in. I think I created one on a periodontally involved upper second molar, I think it was. It was kind of like, how? What happened here? So Sue's mentioned the curved Warwick James, which you would use for taking out 8s, and there is no doubt that if you are just levering between the 7 and the 8 and pushing that 8 backwards, yes, there is a chance that you would break the tuberosity. As far as avoiding it is concerned, I suppose a little bit more palatal and buccal movement rather than less forcing this tooth distally. You can take radiographs beforehand, gives you an idea of the size of the tuberosity. It's not something I ever routinely did for upper 8s. I'm not quite sure how well you could predict the chances of it fracturing. But as I say, I've fractured tuberosity before on a mobile periodontally involved tooth. So as far as preventing it is concerned, I think it's preventing or limiting excess distal movement. But it also gets back to the conversation that we were having earlier on. What happens when things go wrong? Don't panic. Don't panic. We can sort this out one way or another. If you can often diagnose the tuberosity fracture during the extraction because you'll feel it on the palate. You'll feel the palate starting to move, and sometimes the mucosa will tear. And I would suggest stop at that point and don't progress any further. And then you need to get on the phone to your nearest dental hospital or Maxfax unit to seek urgent help for that patient. So, but don't panic about it.
Yeah, absolutely. I mean, I would say in terms of prevention, there's quite a good paper by Bell, 2011 BDJ, if I recall correctly. And I only know that because I reference it in courses that I teach. And it talks about predicting both OAC and fracture tuberosity. So that's basically maxillary antrum complications when taking out teeth. And there are some predictors that you can use that mean it's more likely. So definitely lone standing molars that have been on their own for a while. Older patients, medical history, osteoporosis, that sort of thing. Low-lying antrum, trying to remember what the other ones are, but they're probably the main ones. But that paper is actually quite good. It's really nicely done. There's some nice diagrams and stuff to illustrate. So I'd probably grab a look at that, and that will stand you in pretty good stead in terms of predicting it and preventing it. But I mean, it's something that we all do. I mean, relatively often when you take out an upper 8 on a fully dentate patient, a bit of bone might come off the back. Technically, that's a fractured tuberosity. So you really just need to assess where it's fractured and how big a piece it is before you start panicking, if that makes sense. But yeah, look that paper up. I think it's G. Bell, Graham Bell, maybe, 2011 BBJ, and that has some good information in it on that.
Fantastic, thanks very much, Susie. Got 2 more questions. One's coming on text. Really interesting how these questions get to you, Got one coming on text. When do you suggest that this is a dentist that's asking, when do you suggest that we don't go digging for an upper root because of the risk of displacement into the sinus? Does that make sense to you, ladies?
Yeah.
So what was that?
When do you suggest that we don't go digging for an upper root because of the risk of displacement into the sinus?
Okay. Well, the most common route that's going to cause an OAC and therefore be close enough to the sinus for you to actually push it in is the palatal root of an upper 6. So if it's a palatal root of an upper 6 and you fractured it below bone level, meaning that you're going to have to apply some force with either a peritone or a luxator peripherally on the root to try and create an application point and space to be able to take it out, that's the one that I would feel most nervous about. I'd also, any tooth that looked high risk for an OAC preoperatively, and again, that paper has some information on that about how the sinus looks when it's superimposed, which means that it's high risk or not. So if I felt it was high risk of OAC, then that's when I would be thinking, maybe I don't want to try and get this root out. One of the key things I would say as well with an extraction is if you get so say you're doing an upper 6 and you don't know that you haven't decided you're going to section it, and you get everything moving, if you can get the tooth moving to an extent and then something breaks, then you've probably got a better chance of trying to get the root out, depending on how deeply it's broken, whether it's below the bone or not. So if you know that it's, you've already got it moving, then hopefully that'll mean it's a little bit easier to get out. But yeah, that would be a high risk OAC tooth or a palatal root of a 6 that was below bone. They're the ones I would probably be cautious of. And I actually did that recently. I pushed it into the sinus and I managed to retrieve it through the OAC that I had created with a little bit of good luck and suction. But it is a bit of a brown trouser moment, that I have to say, when you think that you're gonna have to refer them to your colleagues up in secondary care to go digging for it. So yes, that's my view on it. Gillian, anything to add?
Yeah, I think your point about the root being below the bone is an important one. It depends on how much of the root is broken off. If you can still see the root face, and particularly as Sue's mentioned, if the whole tooth was mobile, then hopefully you'll be able to get hold of it with the root forceps. But if you've broken half of the root length or maybe the apex and it's still in place, I would be really cautious about doing something about that. Now, it's whether or not you then go to subsequently try and remove the root at a later date or ask somebody else to do that for you. Again, if you get that patient referred and managed within a couple of days, then actually often removal of fractured apices can be a relatively easy process after a few days. It's almost as if there's a bit of granulation tissue that grows around the side, and the root can often be quite easily taken out. But sometimes you will just obviously leave it to everything to heal over the top, and often these roots may not cause any further problems. But it's looking at your own comfort zone. What's and I think sometimes it's important to look at the bigger picture with the patient. Where's the patient come from? How far have they travelled to get to? Where is it that they're going? Are they a deep sea dive and diving into the depths next week? You want to be really careful about these things. So just look not only the actual treatment that you're doing and the radiograph and the patient and the medical history, but look at the bigger picture as well. And that's true for any treatment that you're doing. I think looking at the social history of the patient is really important to put things into context regarding the ramifications and any complications that may occur after treatment. It gets back to the consent process. Maybe you can chat to us about this at a later date, Suze.
No doubt. Thanks, Andy. Do you have any other questions, or are we?
Thank you both so much. Just one, you mentioned a paper, Susie, I think it was Dr. Bell. Any chance you could share that link with me so that I can share it with a few people?
Yes, I shall dig it out. It will be on my computer somewhere. Absolutely, yeah. I can send you the paper. You want this copy of the paper, you mean? Yeah.
Yeah, or a link to the paper, that'd be absolutely fantastic. A couple of people have just popped it in the chat.
Yeah, of course, yeah, no problem.
Lovely, thank you so much. And thank you, Gillian and Susie, so much for this evening. That notwithstanding our technical hiccups, you've made this evening absolutely. Thank you very much indeed. For all the viewers at home, I'm just going to show you a quick slide now, because you mentioned, remember I mentioned at top of the shop that to get the most out of Simon, the Dr. Simon Nocton session in a couple of weeks' time, you'll need a kit that we're going to send out in collaboration with Guy Sweet. And this is what's going to be in your kit. So I'm just going to show you this slide quickly. Can you see that? Oh, I can't hear anything, so I'm going to assume that's a yes. Great. So this is what your kit includes, all those materials there. If you want that kit, then I'll leave the webinar on after we say cheerio to the ladies. And you can pop your details in the question box, your name and the practice or the address where you want that kit being sent to. And we will send those kits to the first 25 people that put their details in the questions box. And that means that next in the series is part 2 of this particular piece. That's on ridge preservation with Dr. Simon Nocton from the dental surgery in London. So hopefully you can join us for that. That's 7:30 on Wednesday, the 10th of November. And we've already got feedback coming in, Susie and Gillian, that you're absolutely fabulous this evening. Thank you so much for that presentation this evening. Lots of praise coming in on different channels. You're both fabulous. It's one word that's been repeated in my team.
Thank you.
So thank you very much indeed. I think that's it from us. So thank you very much, Suzanne. Thank you, Gillian. And thank you, Simon, if you're still there. I can't see anybody on my screen anymore. I don't know what's happening.
No, it's weird, isn't it?
It is weird tonight. But stay safe, everybody. I'll leave the webinar running for a bit so you can put your details in the questions box. And thank you again. See you next time. Cheerio.
Thanks, Andy.
Thank you, Andy.